I'm Emily Field, an evaluator at USET, and I apologize for being outside, but Fridays are huge video conference days in my house, apparently. To begin with, if you are new to attending these sessions, could you please share your name, email, and affiliation in the chat? If you're on the phone and would like to receive a recording of this after the presentations today, my email is efield, that's E-F-I-E-L-D, at usetinc.org. If you shoot me an email, I will make sure you get added to the contact list. Throughout the presentations, if you have any questions, please share them in the chat and we will get to them at the end. I'm also going to invite everyone to mute yourselves when you are not speaking or presenting, and please don't take offense if I mute you. And then towards the end of the session, I will be sharing an evaluation link for SurveyMonkey. If you could please click the link if it's active, or copy and paste it into your browser and just give us some quick feedback. It's very short. That would be wonderful. And also, we are being recorded. The recording's already on.
Great, thank you. Next, we'll have Taloa Berg do staff introductions for those that are presenting today.
Good morning, everybody. Today we have Christy. She's going to give us some updates on the IHS Nashville area, and then we'll go to Dr. Brown so he can give us the basics of coronavirus, just a refresher. Maybe we'll learn something new as well. And then we're going to April Sells from Porch Band of Creek Indians, who's going to talk about casino reopening and plans. So we'll go ahead and get started with Christy.
Good morning, everyone, or afternoon, I guess, depending on where you are. I see a phone number with a 251 area code, 251-253-5972. April, is that you? Can we unmute that real quick, just to... April, is that you?
Yes, it is me.
Okay, well, welcome. I'm glad you're here.
Thank you.
Okay, while Taloa is loading the presentation, we'll get started in just a minute. It's good to see everybody here. Thank you for coming. This ECHO session is a little bit different from the ones we've done in the past. Typically, they have a pretty heavy-duty clinical focus, but we've been getting a lot of reopening questions, so we decided to take a little bit of a different track this week. So we're really glad April could be here. Okay, go ahead and go to the next slide. I'm just going to give a brief update on what's going on in the Nashville area. Most of the tribes in the Nashville area have been reporting their testing numbers to Christina Rogers at IHS, and she's been sharing that information with us. And you can see that this past week, there have been a total since the COVID crisis began of 4,669 tests conducted, and that's up from 4,154 this time last week. So we've had a pretty significant increase in the number of tests. The number of positives is up by almost 200, where it's 650 now, up from 455. And you can see the number of negatives, 3,880 compared to 3,339 this time last week. So it does look like we're doing more testing. We are seeing an increase in positives. But as of right now, we, across the USET area, haven't seen any dramatic spikes, although that will obviously vary from tribe to tribe. Go ahead and go to the next slide, Taloa, please. This week, we generated a graph of the confirmed cases per 10,000, and you can see the USET counties are a little bit higher and we looked at the CHISDA counties. So these are, you know, the surrounding counties and the clinical service areas. So we see the rate in USET CHISDA counties a little bit higher than that of the USET states and quite a bit higher than the United States as a whole. So we're going to be monitoring this from week to week and to see what's going on. In addition, each tribe is receiving this same graph, except we're looking at only their CHISDA, their state in the US. So you will be receiving this just like you have the past 3 weeks. I believe this is the 4th week that we're sending this information out to tribal leaders so they can monitor the situation on the ground. In addition to this graph, we are also including in the report your testing numbers if you're reporting testing to Christina Rogers. As always, if you feel that those metrics are not giving you the information that you want, please let us know and we can modify your report to give you more updated information or give you something that's tailored that will be more useful to you. And those will be coming weekly, just like they have been in the past. So go ahead, next slide. And again, and I know I ask you this every week, but just keep in the back of your mind, what can we provide or improve upon? What are your greatest challenges during this pandemic? Where do you feel most supported and where do you feel least supported? I know that those aren't questions that are always in the forefront of our minds, but if you have any of those answers that you would like to share with us, it really helps us to tailor our assistance to you guys. So thank you for listening. I'm going to turn it over to Dr. Brown, and we'll flash the contact slide real quick. That's okay. I'll talk about it later. If you need to contact us, you can contact us at our email address. And we have a group email address that goes to all the epidemiology staff. It's usetepi@usetinc.org. So Dr. Brown, I'll turn it over to you now.
I guess it would help if I unmuted myself. Thanks very much, Christy. And good day, everybody. I'm grateful for the opportunity to talk to you today. And even though Christy said this isn't going to be heavy on the clinical side, some of you may think differently after I finish talking. I am going to talk about basics with COVID-19, but there will be because I'm a doctor, it's hard for me to not talk about the clinical aspects. Taloa, if you could advance the slide to the first one. So COVID-19, as probably all of you know, stands for coronavirus infectious disease or coronavirus disease 2019. There wasn't a COVID 1 through 18. It was reported first at the end of 2019, so that's where the 19 comes from. The causative agent is the SARS-CoV-2 virus, SARS standing for Severe Acute Respiratory Syndrome. Most of you remember the original SARS back in, it's been now 17, 18 years ago, an outbreak in China that had fortunately limited spread. This current virus is in the beta coronavirus group. It has a lot of similarity to the first SARS virus, which is why they've named it SARS-CoV-2. Its closest relatives are a couple of other coronaviruses that are found in bats. For those of you who are science wonks, it's an enveloped, positive sense, single-stranded RNA virus. It uses the ACE2 receptor to get into cells in our body. The ACE2 is the angiotensin converting enzyme 2 receptor. This picture is, this isn't really the color of the virus. These are color enhanced electron microscope photos of the virus. And you can see the little spikes on the virus there. That's where it gets its name, coronavirus. It's because it looks sort of like the corona around the sun, or a crown on the head of a person. It's not from the beer. Next slide, please. So it was first reported in Wuhan, China in very late December. The World Health Organization had declared it a disease of concern in January, but on March 11th declared it a pandemic. The US and Europe have been particularly hit hard, but almost nowhere has been spared. And right now we're seeing a really big surge in South America. As of yesterday, there were over 5.7 million cases. I think we're up to 5.8 million now. This is worldwide. In the US, we're approaching the 2 million mark. Some countries have managed to contain it through some rather robust and even extreme public health measures, but it's really been very widespread in the US and Europe and now South America. Case fatality rates have varied from country to country. The case fatality rate in the US as of yesterday was about 5.9%. I'm going to talk a little bit more about what that means later. Next slide, please. So where did this come from? There are lots and lots of conspiracy theories out there, but unless you're just a big conspiracy theory nut, the evidence is pretty overwhelming that this came from bats. There's a fair amount of evidence that it may have gone from bats to an animal called a pangolin. That's a pangolin on the right there. It's actually a mammal, not a lizard, even though it has scales. This is an animal that's found in the southeastern part of the Asian continent, in China and Southeast Asia. There's been a virus found in this that is 99% similar to SARS-CoV-2, and there's the thought that it may have gone from bats to pangolins and then to humans. Interestingly, even though the pangolin looks like a lizard or an armadillo, it's actually a fairly close relative of the civet cat, which was thought to be an intermediate host to the first SARS virus. Next slide, please. And by the way, hopefully there'll be time at the end to answer questions if you have them. So what about transmission? Well, it is mostly person to person from a respiratory source. When people cough, sneeze, or even talk, and especially if you sing, you produce respiratory droplets. These can travel usually about 6 feet through the air before they land on the ground due to gravity. But if it happens to hit one of your mucous membranes, the eyes, the nose, the mouth, it can get into your body and start its replication. It can probably be transmitted from contaminated surfaces, although this is not all that well documented as of yet. Anything that causes an aerosol to be produced, such as a respiratory therapy treatment, a nebulizer treatment, can cause the virus to hang around in the air a lot longer because the droplets are much smaller. And so there's concern that with an aerosolizing procedure, there may be more chance of an airborne transmission, which can actually occur at longer distance. Anytime somebody's involved in being near a patient that has this procedure going on, you need full protective gear, the full personal protective equipment. Otherwise, wearing an N95 mask when dealing with patients is very important. There's also the possibility of a fecal-oral transmission, although this has not really been documented yet in any kind of substantial, but it is theoretically possible as viruses shed in the stool. And then the role of asymptomatic cases is being heavily looked into right now. We still don't know what the actual asymptomatic rate is, but it is definitely theoretically possible that it can be transmitted from asymptomatic people who are carrying the virus to others. Next slide, please. So One of the big problems, and the reason that this has been so widespread, is that people are probably infectious for 48 and possibly longer, 48 hours or longer, before they have any symptoms. So you become infected, maybe a couple of days later, you're producing enough virus to infect other people, but you don't get sick until 4, 5, 6 days after exposure. It is thought to be most infectious early in the course of illness, probably during the first 7 or 8 days of illness. There's a higher risk of transmission, of course, just makes sense, to close household contacts, to healthcare workers who are taking care of patients who are sick with COVID. Studies have shown an average attack rate of about 10% among household close contacts. The R-naught that I'm not going to go into is variable, but it has a fairly high R-naught, which has made it more spread more widely. There have been some super spread clusters of this, several of those reported. There's been some concern that pets can transmit this, although let me be very clear about this. There is no documented case of transmission from an animal pet to a human, but cats and ferrets and possibly dogs can be infected. But it's actually the case that a pet in a household with a human that has the disease is at a lot more danger than the people in the house are from pets. So don't go getting rid of your cats and dogs. But if you get sick, make sure that you treat them like you would the rest of the family and keep them away from you. Next slide, please. So the virus comes into your body, it replicates first in the upper airway, then moves down into the lungs where it attaches to what are called type 2 pneumocytes down in the little air sacs or alveoli in the lungs. These are the ones that produce surfactant, and it's one of the reasons that this can cause such severe disease. It can also cause what's called a cytokine storm that leads to really severe illness. And this picture here, again, this is a colorized version. The virus isn't really purple or yellow or red, but you can see just the huge number of viral particles that are coming out here from a lung cell. This is actually not in a human, it's in tissue culture. But you can see how once the virus invades a cell, it can produce many, many new viral particles. And this leads to the death of the cell. And if you kill enough cells, makes you sick. So that's how people get sick from it. Next slide. It has a typical incubation period of 2 to 14 days, with 14 probably being on the far end. Average in various studies has been around 4 to 6 days. So usually about 80% of people that get symptoms have a rather mild disease being classified as you don't have to be put in the hospital with it. About 20% of people get pretty sick, with 15 of them, 15% being severe, 5% being critical. The case fatality rate, which is the number of people that die divided by the number of people that have laboratory confirmed cases, has really varied from country to country. Belgium has the highest case fatality rate, with 16.3% of confirmed cases actually dying. That's compared to, not too far away, Germany, which has a case fatality rate of 4.6%. The reason for this probably has more to do with the amount of testing. In Germany, they've had a lot of testing, so they're probably picking up a lot more cases. Belgium has a lot of old people, so the older you are, the more likely you are to succumb from the disease. Next slide. So there are a number of risk factors for more severe illness. If you're over 65, you have a higher chance of having severe disease and death. People with various health conditions like heart disease, diabetes, hypertension, lung disease, cancer, chronic kidney disease, obesity, and maybe some forms of liver disease There was one study in Italy of 355 people that died from the disease. Only 3 of those 355 had no apparent underlying conditions. So it's a disease that tends to attack people who are unhealthy to begin with, at least in a severe way. Next, please. So what are the symptoms? The main symptoms are fever and chills, a cough, shortness of breath, and then diarrhea and nausea, at least in this US study. The percentages in parentheses comes from a study of US hospitalized patients, and they're presenting symptoms. So actually in a quarter of cases, GI symptoms were prominent. Other things that people experience: fatigue, loss of appetite, myalgias, sometimes a productive cough, abdominal pain, vomiting. And interestingly, a lot of people have reported losing their sense of smell and taste, and headache, sore throat, rhinorrhea. So as you can see, there are lots and lots of different symptoms. And of course, there are a lot of other illnesses that can cause these symptoms. So just because you have it doesn't mean that you have COVID, but it does mean that you might. Next slide, please. So the complications that end up killing people often are respiratory. People get hypoxic. In other words, they can't maintain their oxygenation levels. They have respiratory failure, acute respiratory distress syndrome, or systemic inflammatory response syndrome. Cardiovascular complications such as heart attacks, arrhythmias, and blood clots are also quite common. And acute kidney injury can occur in a number of patients. So it's usually the complications that are the result in the fatal cases. Next slide, please. Some of the laboratory features: the lymphocytes, which is a type of white blood cell. These are often very, very low. You may have elevated liver enzymes, elevated LDH level, which is another enzyme found in a lot of different tissues, but particularly in the liver. Inflammatory markers such as C-reactive protein, ferritin, the erythrocyte sedimentation rate, and you can see an elevated D-dimer. If you're not a clinical person, don't worry. These are just big words that I had to go to school for a long time to learn how to say. But if you are clinical, these may mean something to you. Next slide, please. So here are just a couple of examples of chest X-ray on the left and a chest CT scan on the right. All those little fluffy white things out in the lungs on the chest X-ray don't belong there. This is obviously a very sick patient. They've got electrode wires, and I see an endotracheal tube there. But this was taken from the X-ray of an older patient that had severe disease, and you can see much of the lung is involved. It's more common for the lower lobes and the sort of peripheral area of the lung to be involved. The CT scan shows sort of the typical, what's called ground glass appearance. This is maybe not all that apparent to people who aren't used to looking at CT scans, but it's the lighter area there in the lung tissue, and this person has extensive involvement. Next, please. So how do you make the diagnosis? Well, there are a number of ways to do it. First of all, you suspect it from symptoms and physical exam and some of the laboratory values, or chest X-ray, chest CT. But the way to confirm the diagnosis is with a diagnostic test. This usually is a so-called reverse transcription PCR. PCR stands for polymerase chain reaction. Don't worry about what that means. It's just a type of test that tests for the RNA of the virus. These are usually obtained by either a nasopharyngeal swab or some other swab of the upper airway. Lower respiratory specimens such as sputum will usually yield a higher rate of positivity, but they're harder to obtain. There is one antigen test that's currently approved by the FDA. The problem with this test is that it's has good specificity. In other words, you're not going to get false positives from it, but it only has about 80% sensitivity compared to PCR. So that means 20% of the test will give you a false negative. There are currently 12 antibody tests that have FDA approval. These tests for antibodies to the virus, these are usually not positive until usually late in the second week of illness. There's limited utility of an antibody test for making the diagnosis of acute disease, but it may be very useful in studying populations to see how many people have had the disease. Next slide. So the treatment for COVID-19 really at this point is mostly supportive. So it's really important to not get it. Most cases, at least 80%, can be managed at home. But some people require hospitalization, especially if they're not keeping up their oxygen levels. The really severe ones often end up on ventilators for ARDS and respiratory failure. As of right now, there's no proven medication. The antiviral remdesivir is showing some promise. Unfortunately, the antimalarials, chloroquine, hydroxychloroquine, at this point, there's not much evidence that they do any good. Some other drugs are being studied, ones that interfere with interleukin-1 and interleukin-6. These are inflammatory cytokines that are seen later in the illness. And then there's been a lot of interest in actually some evidence that convalescent plasma, that is, you take plasma from people who have had the disease and recovered, and you give it to people who are sick. And hopefully the antibodies in the plasma attack the virus and help the person to recover. Next slide, please. So what about vaccines? Everybody, I think, is very interested in vaccines. And as of Wednesday this week, there are 125 different vaccine candidates worldwide that are in some stage of development. There are 10 of these vaccines that are currently in clinical trials. That is, they're in human clinical trials. They use several different approaches, some old approaches to vaccine and some very new. Question is, when will they be available? I wish I knew the answer to that. I don't think anybody knows. Probably the most optimistic expectation would be early next year. I'm just hopeful that there'll be something out by next spring or summer. I mean, it'd be great if we had it sooner, but you know, it takes time to develop. So anyway, I'd be open to questions. I don't know if we want to wait until the end of the presentation to take those, but if you do have questions anytime that you want to contact me and ask me, I don't promise that I know the answer, but I'll try to find it out. That's my phone number down there at USET. So thank you very much.
Thank you, Dr. Brown. There is a question in the chat. We'll go ahead and get that. It says, I just came from geriatric grand rounds with an update on HIV. One part was the dementia of HIV felt to be related to the cytokines of the brain. Interestingly, several of the participants postulated that the lengthy cytokine storm of COVID-19 might leave us with a group of patients with COVID-19 related dementia, though possibly one that will improve over time. Is there anything more known about this at this time?
That's a really good question, and I'm sorry, I really don't know anything definitive about that. I've read some about the speculation and the apparent dementia that some people have suffered from COVID-19, and I think at this time we don't know how long it will last. Of course, there's always hope that people would recover. I don't know if Dr. Mira has any other information or anybody else on the call that might know more, but I really confess that I don't have a lot of knowledge about that.
No, I don't have any anything to add?
There's so much that's still unknown. This disease is, I mean, as I think Dr. Mira said one time, if the information is more than a week old, it's out of date. Certainly as I was preparing for this talk, you know, a lot of the stuff I was looking at is hot off the press, really.
Great, thank you. Are there any other questions for Dr. Brown at this time? If not, we will move on to April Sells from Port Japan, Wind Creek Casino. Hello, do you want to pull up our presentation? Gotcha.
Hear me? Thank you. I was waiting to be unmuted. Good morning, everyone. So I'm going to talk to you briefly about Wind Creek Hospitality's COVID-19 response plan and our way that we have chosen to reopen our facilities, even though we have been given the go-ahead to open approximately a week ago today. Next slide, please. Let me begin with what led us to doing a guest survey for all of our guests who has attended our properties in the past. March the 13th of this year, I was contacted by a representative of the Wind Creek Hospitality corporate office at approximately 11 o'clock one night. And they informed me that there was information going across the game room floor that a possible individual had tested positive in Elmore County, which is the location of our Wind Creek Wetumpka property. The next morning, I was able to get on the phone with public health, work with them to try to trace the validity of that information that was given to us by guests. And we were able to target the date and time in which that individual was on property. We worked with our marketing department, and we chose to close the offices and all facilities as of March the 15th, 2020 at 8:00 a.m. just to be on the safe side, to make sure that we were very concerned with not only our team members, but our guests as well. So we decided to close the doors. That led us to making sure that as many people that we could have working remotely, that we would do that from all the tribal properties when it came to gaming and tribal government, at which time those individuals who were working from home, they were given a list of guests and certain questionnaires that they needed to call guests, find out where they were, what was going on with them, did they need anything, were they provided necessary resources that they need to combat COVID-19. And we were able to get a feel of what opening day would look like when we decided to reopen. And keep in mind, at that point in time, we expected to be down for approximately 2 to 4 weeks and then reopen again. And needless to say, that is not what happened. Next slide, please. So what we did is we decided that we would develop a health task force. The reason why we decided to do that is because from the emergency management standpoint, we had corporate people, and we had people that was looking at the business aspect of our gaming operations. but we needed somebody that was on the front lines dealing with COVID-19 patients on a daily basis to give us as much information as we could possibly gather to determine how we needed to open, what measures needed to be put in place, not only for our team members, but our guests that was coming back. I was fortunate to be able to attend a call with Alabama American Red Cross. On that conference call, we had an individual by the name of Dr. David Thrasher. He was the guest speaker that day. One thing led to another, and sometimes fate has a funny way of putting two people together, and us needing his expertise throughout this process of us getting people back into the workforce. Within a matter of days, he was a part of our health task force, and Dr. Thrasher intubated the first COVID-19 patient that needed to be intubated in the state of Alabama. And last weekend, he made rounds and attended to about 140 patients in the Montgomery, Alabama area. He was recently on CNN discussing the importance of taking things one step at a time and doing a phased approach to open the economy up, and a systematic approach that will make it safe for everyone. Dr. Thrasher also takes a look at numbers of people that is testing positive and what the hospitals around us are experiencing, so that we know day to day what our statistics are currently looking at and know what we need to do to work on reopening, which we will make that initial opening on June the 4th. Next slide, please. As previously mentioned on this call, this is a virus that is continually evolving. We have written and torn up so many plans that we don't know what numbers we are currently on. We would write a plan. We think that would be excellent. We think we had done the best possible job we could possibly do. Then all of a sudden, next day, we gather new information, we gather new data, and we would have to go back, start all over, look at the plan, discuss the plan with Dr. Thrasher. He would look over the plan, and then he would make adjustments to what needed to be done to make it feasible for us to open in as safe as we can. Next slide, please. Physical measures of each facility. Of course, each facility, anywhere that we're going to have one-on-one contact with potential guests or other team members, there's going to be splash guards. There's going to be one way in, one way out. There's temperature checks, non-invasive temperature checks. We are checking team members' temperature as they come through the back doors before they even come onto the game room floor. We will be conducting surveys to make sure that they have not experienced any of the obvious symptoms of COVID-19. If there's people in their family or they're taking care of loved ones. And we have went a step further with that. I know that I will talk about that on the next slide as well. But we went to the point to make sure that team members had enough time to take off to take care of themselves and their loved ones and children if they need to during this particular situation that we're currently in. So we have written a new policy that allows them to take off more time after we start opening doors. We don't want them to feel that they need to come to work ill, or that they need to come to work and leave their loved one at home that is sick. and come into work and be fearful that they will not have a job with us. So we are working closely with everyone to make sure that they are not in that particular situation. And I saw a comment, yes, Dr. David Thrasher is a leading pulmonologist in Montgomery, Alabama, where one of our facilities is located in the middle part of the state. Next slide, please. Personal measures, including proper PPE and training. We have went to great lengths to make sure that this happens. As a matter of fact, my team is in the process of fitting everybody, doing fit tests. We went through every job description. We determined who would be one-on-one with possible guests. We looked at who would be behind splash guards. We looked at housekeepers, people on the game room floor cleaning, people who are administration that's on the second floor. We took every job description and we determined what level of PPE they needed to have in order to safely return back to the workforce. Now what we've done is we have to train them on how to use and how to take care of and how to properly clean their PPE and how we are measuring that. Most people do not know how to properly wear PPE. They wear it up under their chin. They wear it with one of the bands on their ear and think they can wear that and it will make them safe. We even went as far as teaching them proper hand washing skills and when and when not to use hand sanitizer and when to make sure that they keep their hands clean. So we have went to great measures to work with them one-on-one. We developed a slide presentation and information gathering, but I've tried to encourage the risk manager that slide needs to be updated as mentioned earlier. Information changes day to day, so if we don't keep that slide presentation up to date, then the information that is contained in that particular document is old by the time every team member gets an opportunity to look at it. Next slide, please. Crowd capacity. So when we open up the doors on June the 4th, we will only be opening with a soft, what we considered a soft opening. We will have 4 5-hour sessions. We will have an hour in between each session to thoroughly clean the environment. We will clean machines down. We will clean chairs down. We will do a deep clean at the end of 4 shifts, including a product that we decided to look. We vetted products all over the country, and the best product that we came up with was a product called Shockwave. So we have MSDS sheets as well as FDA numbers on the site. We had a company come in and properly, first of all, we had them to properly sanitize all of our facilities, from tribal government to Creek Indian Enterprises, including Wind Creek Hospitality facilities here in the state of Alabama. And then we had that same group come in and show our team members how to clean, what not to, most people forget underneath cleaning. We needed to make sure that they needed to know the proper techniques that they needed to learn in a short period of time of how to properly sanitize. Now, tomorrow, Monday and Tuesday, we're actually going to do a personal walkthrough of each property to make sure that not only is life safety intact, but also make sure that we have covered every possible situation that we can think of that we may encounter when we do the soft opening. We want to make sure that the team members feel safe as well as our guests that's coming to the property. And then if that is okay, then what we will do is open as of June the 8th, at 60% capacity of what we're accustomed to handling. We also, not only do we have sneeze guards or other protective measures for our team members, but we have placed those actual sneeze guards around each machine so that those individuals will be feel safe if something should happen, and it also protects our team member if a guest needs personal assistance. Next slide, please. And of course, because we're opening, unlike other facilities in the general area around us, we are getting a lot of pushback from that, which we expected. Everyone expected us to open the doors and just let everyone in at 50% capacity, but we have chosen not to do that. We have chosen to only allow 249 people in per session. So that gives us an idea of what we're looking at. It also gives our team members an idea of how we need to handle this opening. And if there is any problem that can be created or will be created, and we know there's going to be problems. We understand that, but it gives us a few days to be able to go back and solve those problems in a systematic manner. We're also getting a lot of pushback to us not allowing smoking on the game room floor because our health task force feels that the smoke can easily transfer the virus from one guest to another. We're getting a lot of social media complaints about that. We will, however, allow them to go outside. We will designate an area outside of the facility for them to go and smoke if they so choose. But for now, unless things change between now and a week and a half from now when we actually open at 50%, we will not allow smoking on the game room floor as of now. I think that's the end of the presentation, unless there's any questions or however you guys wish to handle questions.
Great. Thank you so much, April. Does anybody have any questions for April Sells? Or for Dr. Brown or Christy?
So I would like to just make a comment to April that I was so impressed when we talked about everything that Wind Creek and Porch Creek was doing and the amount of detail that was put into your plan. I know that that took a lot of work, and I think that they had a lot of very innovative approaches. I especially like the 5-hour gaming period that they were going to adhere to, and then in between cleaning. I thought that that was a fantastic idea. I know that there was talk early on about maybe programming the reservation system, about allowing a certain number of reservations, and that was something that I had never even considered. And as an epidemiologist, you know, I work in the public health sphere and not necessarily in the industry sphere, and so I learned a lot in my conversations with Porch Creek. And so I just wanted to give them a shout out for all the hard work that they did. And I do have to say, we especially like the no smoking. We're public health people after all, so that makes us very happy. Although I know that that can be a sensitive issue within tribal communities, but just know that the public health staff were kind of quietly cheering you on for that one.
Well, thank you for that. And as a matter of fact, that's the reason, unfortunately, that's the reason why Jay could not join us today during this presentation, because he is handling the marketing portion of just that no smoking policy right now. He's going back and forth, and we're developing a big marketing campaign regarding why we don't want to have smoking on the game room floor. We don't want to be in a situation in which we are allowing people in. Most people doesn't realize that, yeah, they can pass the temperature check, but once they get into the property, they could easily be positive. And right now, we just don't want to have to put that fear in our other guests or the remainder of our team. And as far as hotel reservations, yes, we're going to open up on a very limited amount. We're not going to fill up a floor. Actually, we're going to one opposite side, and we're going to put 2 to 3 rooms in between everyone, so that when people go up to their room, they will not, there's a likelihood they will not pass each other in the hallway. And we will allow or will offer free face covering for those individuals who should decide to come and join us for our beginning gaming operations again.
Thank you, and I'll make a connection with you. We have a connection of somebody that's worked on smoke-free casinos. They may have some resources that can help you, some educational materials.
We appreciate that. Thank you.
Brian, there was a question in the chat about pangolins. I'd be happy to say more about pangolins if anybody wants to hear about them.
They were actually kind of cute.
They're very cute little mammals, even though, like I said, because of their scales, they look like lizards or armadillos or something. Their scales are made of keratin, just like our fingernails.
Yeah.
And this is for protection. Interestingly, they can also produce, like skunks, a very noxious gas from from some glands in their backs, their hind legs. This is apparently the most trafficked animal in the world. The scales are used for all kinds of traditional Chinese medicine. The list of things that it's purported to treat is very long. But also the meat is apparently considered a delicacy, and a lot of them are hunted to be eaten. There are 8 different species in the world. 6 of those species are in Asia, 2 are found in Africa. And 3 of those species are critically endangered. 3 more are considered endangered, and then 2 are on, the list of might become endangered. So it's illegal to traffic these animals, but people do it. So, and probably because they are so highly trafficked, that may very well be how we got to where we are today with the pandemic. At least that's the theory.
Great. Any other questions or comments for today's panel? Just want to draw your attention to the chat box. There is the evaluation link. If you will click on that and give us your feedback. And if there's no more questions, we can go ahead and end our session for today. Thank you all, and have a great weekend.